hearing aids are probably the most widely known form of intervention for people with hearing loss. And they're appropriate for people that have mild, moderate, moderately severe forms of hearing loss. Now, a hearing aid is, at its very best, an amplifier. It makes sounds louder so that they are more loud than what your hearing loss is. They make sounds audible to you. They don't fix your hearing loss, rather they just make sounds amplified so that you can hear them. This is much different than glasses. When I put on my glasses, I've got 20/20 vision. But when you put on a hearing aid, you don't have normal hearing. You just have sounds that are louder in your ear. This is a problem because when sounds get amplified too much, they start to sound distorted. Much like the speakers in your car or at home, when you turn up the volume too much, it starts to sound distorted to you. You've probably all heard this when sounds are really loud. So that's a problem because people have to make sense of this amplified sound, and if it's not clear, it's going to be difficult. In addition, we're introducing amplified sound to a disordered system. These people that are using hearing aids have hearing loss, so there are distortions in their auditory system already. So making a sound louder isn't always helpful because there's distortion at the level of the auditory system. In addition, hearing aids don't know how to selectively amplify sound. So if we were in a huge party and I was trying to hear this young lady here, my hearing aids would be pulling in everything. They don't know that I'm trying to listen to just this one person. Rather, they're pulling in everything around me. And as we have hearing loss, our system loses the ability to separate speech and noise. So that's a huge problem with current hearing aids. If you have family members or friends with hearing aids, they'll probably tell you that background noise is a real problem. And some people even take them off when they get to restaurants or loud places because they just can't manage hearing all that background noise along with the speech that they're trying to hear. If any of you are engineer related or have an interest in electronics, if you could come up with some slick algorithm that hearing aids could use to selectively pull out speech and not amplify noise, you would have a great calling for this industry. Hearing aids are expensive. They cost thousands of dollars, sometimes $2,000 to $3,000 each. That's about $6,000 for a pair. And insurance doesn't always cover hearing aids, especially for adults. So that's a problem. Now we've got this technology that is effective for people, but may not be accessible due to financial constraints. A recent form of hearing aids are called personal sound amplification products, or PSAPs. The attractive thing about a PSAP is that it is affordable. So these often run, maybe $100 or a few $100s. So financially, they're a lot more accessible. They're not custom made to the person's ear. Rather, they have kind of broad amplification that you could just put on anyone, but they're accessible. And so someone who can't afford to get custom-made hearing aids could afford to get one of these devices. And that may be sufficient for overcoming some very mild, moderate types of hearing loss. So I'm a big fan. I like this idea. I like the idea of accessibility and affordability so that everyone has access to improved hearing. I don't love that they're not customized, but I do love that they're affordable. When hearing loss gets really severe, then it becomes so damaged that hearing aids are no longer effective. If those hair cells are completely destroyed, there's really no sense in making the sounds louder because the inner ear is so damaged it can't make use of it. So this is an example of someone that has normal hearing in the low pitches, but then it drops off steeply to to level of profound hearing loss in the high pitches. This person might hear vowels but no consonants. And that's a problem because if you can't hear the consonants, speech doesn't sound very intelligible. It just sounds like Charlie Brown speech, like wah, 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 wah. So this person would not have very good speech understanding. In these cases, when a hearing aid is no longer effective, then we can start to think of intervening with a cochlear implant. A cochlear implant is an auditory prosthetic that has two pieces. It has an implantable part that is placed under the skin through a surgery, and then some external pieces that look like a behind-the-ear hearing aid. The hearing aid portion is called a processor, and the processor is able to capture sound, code it, and then send the information across the skin on a radio frequency to the internal device. That signal carries the information about sound, and it also carries the power for the internal component. So the internal component is not powered up unless you've got the external piece on. When the external piece is off, you don't hear a thing. When the external piece is on and working, that sends the information across the skin, powers it up, and then sends information to the piece that eventually gets implanted into the inner ear. The part that's implanted into the inner ear is called the electrode array. And the electrode array has several contacts that thread through that snail-like structure. The idea is, if you can place those contacts along that inner ear, along the cochlea, you can then drive those nerve fibers to respond. And because the cochlea is organized with high pitches at the bottom and low pitches at the top, we know that we're stimulating different pitches, a different range of pitches, so that we can represent speech. So this would be an example of a healthy inner ear, where we've got a row of inner hair cells, rows of outer hair cells, and everything looks just the way it should be. Here, in this model, this is a chinchilla who is exposed to really loud sounds, about 90 dB, for 8 hours, 6 months earlier. And you can see that the hair cells are completely missing, or they're so damaged that they're no longer functional. So this ear would not respond to sound. Those hair cells are so damaged that there's no making use of them anymore. Amplifying sounds and using a hearing aid would not work in this ear. This would be somebody that we'd want to consider for a cochlear implant. And the implant would bypass these hair cells and stimulate the auditory nerve fibers directly so the person could hear some level of speech. Are any of you squeamish? Well, it doesn't really matter because I'm going to talk about this anyway. The implant surgery is done obviously by a medical physician, and the surgery takes about 3 hours. It's done on an outpatient basis. So you go in the morning, you have surgery, and then you go home that day. You don't have enough blood loss to have a blood transfusion. You do have to be anesthetized and intubated, but it's considered relatively minimally invasive because you don't lose a lot of blood and they don't have to go very far into your ear to do this. The surgeon makes an incision right behind your ear, then pulls the skin back and drills through this bone. When they get to the inner ear, they thread that piece into your cochlea, place the electronics up here under your skin, and then close the whole thing up. So from a surgeon's perspective, they would consider this relatively not very invasive. From our perspective, it sounds pretty severe. I mean, they're going to open up my head and drill through some bone. That sounds pretty invasive to me. But from a surgeon's perspective, they don't consider this very invasive. This would be a picture of somebody that's getting ready to have cochlear implant surgery. In this case, they've shaved this part of the head, and then they've sterilized it, and they've placed a sterile sheet over here so that nothing can get into this area that could be infectious. This is a pretty old picture. They typically don't shave the head anymore. You don't need to. In these days, there was a lot of caution taken to make sure that no hair would get close to the incision site, but that's pretty uncommon now. You can see the surgeon has marked where they're going to make their first incision. So they're going to make this kind of S curve here, then they're going to pull this skin back. If we could skip forward through the incision, through all the drilling, we would eventually see this perspective here, where we're looking through the mastoid bone, and this hole right here on the other side is the inner ear. So it's not a very big space. And it also really drives home the idea that the inner ear is not this standalone structure that you can then visualize, but rather it's encased in bone. So when the surgeon goes to implant the electrode array into the inner ear, it goes in blindly. The surgeon sees it going into the hole, but then they don't see it anymore. They lose sight of it. And it goes into the bone and then coils around the cochlear structure. This is a close-up of that viewpoint. The inner ear is right beyond here. This is a round window that connects to the inner ear. It's a membrane that goes to the inner ear. The surgeon could implant the array through that membrane. He or she would make a small incision and implant the array through there, or they could drill through this bone and create what's called a cochleostomy. It's a hole in the cochlea, cochleostomy. And then insert the electrode array there. Once the array is in place, it looks like this. So again, you can't see that the array is coiled up into the inner ear. We just have to take it for, we have to take the surgeon's word that it went in smoothly and hope that it's in the right spot. Before they let this patient wake up, they would bring in some radiology folks and do an x-ray to make sure that the array is in the right spot. You can do what's called a plain film x-ray, and if you see the array spiraling up like this, then you know you're in the cochlea. If the array is just a straight line, you're not in the cochlea. You're probably somewhere else. It does happen once in a while, but it's pretty uncommon. The external pieces have changed considerably over the last 3 decades. The first cochlear implants were done in 1982, and since then, the external pieces have been miniaturized and digitized to the point where they can be very small and more discrete. The first processors were these big box-like things that you'd have to wear on your belt, and there would be a cable that would go up to your ear to transmit the information across the skin. They became smaller and smaller and smaller, and eventually they became small enough that you could hang them on the back of your ear. The current devices look like this. So there's a processor. The bottom part is a battery. There's a cable, goes up to this piece that's a transmitter that transmits the information across the skin. This is another example. There's the processor, there's the battery, the cable, and the transmitter. These ones are newer, and they're called off-the-ear processors. They just look like buttons that stick to your head. The internal piece has a magnet, and the external piece has a magnet, so it sticks to your head by magnetic attraction. The only function of the magnet is to keep it on your head. Everything else happens electronically. There's no connections that go through your skin. So when you take it off, you can shower, you can bathe. There's nothing you can see that would make you know that you had a cochlear implant. The outcomes from cochlear implantation are amazing. These are some data that I collected a couple of years ago, looking at consecutively implanted postlingually deafened adults. That means that the people were deafened after they learned spoken language. So they already had a mental representation of what spoken language was and then lost their hearing. These data are broken down by age groups. So we have adults that are less than 60 years of age, adults that are 60 to 69, 70 to 79, and then 80 plus. What we're seeing along the x-axis are their scores when we tested them with their hearing aid before surgery. This test is a single word test. So the presentation may sound something like, say the word ball, say the word dog, and the person would reply back. They would say ball or dog. If they got it wrong, then of course they would get 0. We can score that test as a whole word, or we can score it by the number of phonemes that there are. There are 3 phonemes in a monosyllabic word. Ball has 3 phonemes, b, a, o. So we can score that as a whole word correct, or number of phonemes correct. So if the presentation was, say the word ball, and I said bald, I would get credit for the b and the ah, but not the ald. This test is a sentence test. So the presentation might sound something like, the boy ran down the road. And the person being tested would be expected to say that back. They get scored for the number of words they get correct. So if they said, the boy ran down the path, they would get all but one of the words in that sentence. So these are their data with their hearing aids preoperatively. And you can see that everyone's scoring pretty poorly. These people are scoring on average about 15% correct. It's a pretty easy test. You're just saying, say the word ball, say the word dog. So they have so much hearing loss that they're not able to get just that single word. Their sentence scores are a little bit better because you can hear just a couple of words in a sentence and start to fill in the gaps. So if the sentence was, the boy ran down the road, and I heard boy ran down, I might say, well, the boy ran down the road, just as a guess. But because I could get some pieces of information, I could fill in those gaps. So sentence scores tend to be higher than word scores. These are their data at 12 months after having cochlear implant surgery. If we were to take these scores and collapse them, we would see that adults who lose their hearing later in life score on average about 67% correct 1 year after surgery. And they started at about 15% correct. So the outcomes are profound. You're taking someone that has relatively no hearing, no usable hearing, and partially restoring it, enough that they can hear speech so that they have great improvements. So you can imagine that this person is having probably a much easier time understanding speech than they did before surgery with their hearing aids. What's of interest is that the scores are different for younger adults compared to older adults. This speaks to the idea that older adults have damage to their hearing structures, but they also are facing damage to the way that they can interpret or process sound. So older adults tend to be slower in processing sound, and there tend to be more central effects that we can't overcome with a cochlear implant. These are data for hearing speech and noise. When we think about testing speech and noise, we want to know how loud does a speech have to be above the noise in order for us to hear it 50% correct. For those of us with normal hearing, we're probably able to hear speech when speech is equally loud to noise. But somebody with hearing loss needs the speech to be much louder than the noise in order to hear it correctly. So people with hearing loss tend to need a greater signal-to-noise ratio to hear speech accurately. So on this graph, we see on the y-axis a signal-to-noise ratio. How loud is the speech over the noise? And on the y-axis, I've plotted the different age groups. So the younger adults and then the oldest adults. The blue marks show the hearing levels before surgery. So this is how loud they needed the speech to be above the noise in order to hear it 50% correct. And then the lower scores are from their 1 year post-activation, post-surgery test interval. And you can see a dramatic change in how loud the speech needed to be for the people to get 50% correct. So it could be much softer and they could hear it accurately through their cochlear implant. So the effects of cochlear implantation are not only just for quiet listening conditions, but also for complex listening conditions like listening in excessive background noise.